There we go. Sorry about that.
All right. Can you see and hear me?
Yes, we can.
Yes.
Dr. Mian, and am I saying your name correct?
Yeah, that's great.
Okay. Awesome. Well, thank you so much for your time today. So my name is Paula Ransom. I work with Parkinson's Point. So I work very closely with Meredith, and I'm responsible for our different volunteer components of the organization, including our board of directors, of which Greg is a member of. So we're really excited to have you today, Dr. Mian. And since we have such a small group, why don't we just let Greg and Brian introduce themselves quickly, and then Dr. Mian, I'd love for you to introduce yourself, talk a little bit about you and your background, and then we'll allow you to launch into the great information that you're going to share with us today.
Sure.
Greg, do you want to start?
Sure. I'm Greg Richer. I was diagnosed with Parkinson's 4/26 of 2011.
Mm-hmm.
I had deep brain stimulation surgery bilaterally through the STN with Boston Scientific equipment on 4/26/23 on the 12th anniversary of my diagnosis, which I find ironic. And I'm currently writing a book about the experience of choosing, why did I choose to go through DBS, and why the type of DBS, and why did I pick the doctor, and so forth. I call it the ABCs of DBS. At the beginning of my book, there are no fewer than 31 three-letter acronyms.
Wow.
For something that has to do with DBS, like deep brain stimulation, or VIM, or STN, or GPI, or any number of things. So, so kind of a how-to book, so that people, because when I look around for stuff like that, I don't find too much. Either people that don't have DBS don't want to write about it or talk about it, or are too scared maybe to talk about it, because it is, after all, deep brain stimulation. But and I was instrumental in helping get Parkinson's Point started a long time ago. I'm on the board of directors. I don't know that I have an official title on the board, but I just collect a lot of money because I have a lot of wealthy friends, because I was a warlord of commerce for about 35 years in the Colorado market. I now live in Pensacola, Panama City Beach, excuse me. That is Gregoire. Brian.
Thank you, Greg. Brian?
Yes, Brian Hunter, Denver, Colorado. I was diagnosed December the 12th of 2018. I'd heard of Parkinson's, but I didn't know what it was. I was diagnosed based on right-hand tremor at rest and not swinging my right arm as much as my left arm. I dove into the internet and tried to learn everything I could about it. I stuck to articles that were peer-reviewed, like NIH, because a lot of the articles are about selling a product or a service. And you don't want to take that for gospel. My symptoms are progressing very slowly, and I'm very happy about that. I'm very grateful, actually. So I never ask why me, I ask why not me. There's nothing that I did to get this, and there's nothing that I did that would prevent it.
Yeah, Brian, wouldn't you agree that probably from your knowledge of Parkinson's people, sorry, I'm dropping my lunch all over the floor, that the people with Parkinson's that accepted the best, that attributed to a cause or a reason, a higher cause than themselves, tend to do far better with their Parkinson's than the people who sit around and, oh crap, I have Parkinson's and my hand shakes and I too was right side tremored. That's not the tremor, that's me moving my hand. But I have a belief that people with belief tend to do far better with their Parkinson's than people without a belief system.
Well, that comes through in your book very nicely. Or at least your older book, Rising Above Parkinson's.
Yeah. Yep. Yeah, Dr. Matthew, what do you go by?
You can call me Matt, sure.
All right, Matt. I wrote a book called Rising Above Parkinson's 2 years ago, 3 years ago, something like that, back in 20. And again, just trying to give people a sense of hope. So many people think of Parkinson's as this death sentence. And I do a lot of public speaking for Parkinson's. And I always ask the audience, raise your left hand if you're not going to die. Now that I've established we're all mortal, raise your hand if you want to know what you're going to die from. And the research that I've done, I know that back in I found a real old document. Back in 1970, they said the average person would live 8 years beyond their diagnosis with Parkinson's. Today, what I generally read and hear about is that maybe Parkinson's will take 3 years or 5 years off of your life, your natural life. But that, quite honestly, if you don't let it, it doesn't kill you.
Yeah, I
Now,
mean,
do you
we've come a long
fall?
way. We've come a
Yeah.
long way. And as you referenced, there's a sizable percentage of patients now that they die with Parkinson's, not of Parkinson's, if that makes sense. And so, of course, it strikes different people differently. But as you say, you're your best advocate. And whether it's through attitude, lifestyle changes, exercise, seeking medical care, all of these things have a huge impact on how people do, I think, as you're saying. So absolutely.
Absolutely. Believe that 100%.
Yeah.
Wonderful. Well, Dr. Mian, thanks again for joining us today. So why don't we let you tell us a little bit about yourself and your background, and then
Sure.
I know that you're preparing to share some the latest advances in surgery for people living with Parkinson's, and then we'll also make sure we have some time for questions after.
Yeah.
Speak.
So why don't I can pull up my slides here if I can figure it out. Are you
There we
guys
go.
able to see that?
Yes, we can.
All right, I'm going to try to full screen it, and just tell me if you have any. Oh. Sorry, let's try that again. Today seems to be the day of technical issues, huh?
Yes.
Okay, can you see
There
that?
you go. Mhm.
Great.
Yes.
So my name is Matthew Mian. I'm a surgeon in Denver, and I focus, among other things, on movement disorders. And it's a passion of mine, and I've been doing it now here in Denver for 4 years. And I find it a really rewarding thing to do. We have Greg, who can speak. I know it's recent, but can start to tell us a bit about the benefits of Parkinson's, and I'll go over some of the data that we have to support that. But it's really meaningful because I see patients back, and they generally do really well, and the kinds of things that I'm going to describe today are pretty impactful. Nothing's perfect, and we'll go over some of the risks and disadvantages of the procedure, but it's a great procedure and I do it a lot. And, you know, in fact, I did one this morning. So a little bit about my background. This is, you kind of see where I trained and stuff, but like I said, I've been in Denver here for about 4 years and try to be really actively involved in the local support groups and everything related to Parkinson's here. So
Good.
with that, I'll kind of jump in. And so we can keep this pretty interactive because it's a small group. And so feel free to jump in if there are things that I say that don't make sense or you want me to clarify something. But I thought we could start with a little bit of background on Parkinson's. I'll talk about brain surgery, not just DBS, but some of the other options we have nowadays. And then we'll finish by talking about what's kind of changing, what's the latest and greatest, and where are things going. Okay.
That's good.
So, you know, some of this may be very familiar to you, but if we're recording this and folks see it later, Parkinson's disease is very common, despite the fact that many people who are afflicted never have heard much about it. You know, it affects, we think, about 1% of people over the age of 65, and we're seeing the incidence growing in the United States. And a large driver of that is just the aging population. But right now, we think there are about 1 million patients affected in the US alone. We know that Parkinson's is caused, or the symptoms are caused by a gradual loss of cells in the brain that produce a chemical called dopamine. But we have various theories. We're not sure why these cells start to disappear over time. We know risk factors for Parkinson's, head injury, pesticide exposure, and so on, but we're not sure what the causative process is that kindles this, that starts the process of cell death. What we do know is that a loss of dopamine in the brain affects a variety of things, but among them is a part of the brain called the basal ganglia. And we know that these abnormal rhythms develop in the basal ganglia that are correlated with the movement symptoms that are familiar to all patients with Parkinson's. The place in particular that we notice a loss of dopamine in the brain is called the substantia nigra. It's this, can you guys see my mouse?
Yep.
Okay.
Yes, sir.
So it's this dark stripe that you can see here. You have one on either side. It's actually deep inside the brain, at the base of the brain, in what's called the brainstem. And if you take a section of a brain of a patient with Parkinson's disease, you'll see that this stripe is less dark. And I think I have a slide of what that looks like.
Yeah.
So here's a patient unaffected with Parkinson's disease, and by comparison, you can see that there's a loss of these dark cells in the substantia nigra. You know, that of course requires that we section a brain, so that's not a living person, but we have scans that allow us to try to get at those findings. These scans are not perfect, and they're not, you know, the centerpiece of any diagnosis of Parkinson's disease, but they can support what a doctor may suspect clinically based on a history and a physical exam. And the mainstay of those scans is something called a DAT scan, which just looks at dopamine uptake in the brain. This is a control patient that does not have Parkinson's disease, and you can see that there's a progressive disorganization or scattering of the dopamine uptake as the disease progresses. And so, again, this is something that's sometimes used as a supportive tool for a diagnosis, but it's not a linchpin in terms of making the diagnosis. And dopamine, it turns out, is something called a neurotransmitter. It's used to signal between nerve cells. And so it exists in this cleft between nerve cells. So one nerve cell is trying to signal another. It releases dopamine. As that gets lost, neuronal signaling is affected. And this can result in a variety of effects on the body, but among them are the movement or motor symptoms. So the cardinal ones being bradykinesia, or slowness of movement, rigidity or stiffness, the tremor, the resting tremor that both of you referenced. And then as the disease progresses, postural instability or difficulty with gait and balance.
A quick question,
Yeah.
Doc, if I can.
Mm-hmm.
Doesn't it strike you as odd that tremor, generally a resting tremor for those of us who had it or have it, is involuntary motion. You're always in motion. I've had to learn to eat and shave and do everything left-handed. I've become ambidextrous because I can't do anything with my right hand, or couldn't prior to the DBS. Don't you find it interesting that in the motor symptoms of Parkinson's, one of the dominant deals is tremor, this movement. But the other two major components of it are the dyskinesias and the bradykinesias, the slowness of the movement and the rigidity. Don't you find that odd that it's like opposite ends of the spectrum?
Yeah, so it's an interesting thing. So dyskinesias, as you mentioned, actually we think relate to having too much dopamine. So, you take a dose of Sinemet or levodopa, it peaks in your bloodstream. And as the disease progresses, I think I have a slide on this, the dopamine level actually will overshoot what you want. And the dyskinesias, we think, mostly happen when the dopamine is too high, okay?
So the jerky movements, dyskinesias,
the
right?
kind of writhing, it looks like people are fidgety or dancing. We call those dyskinesias, and those typically happen when dopamine is actually too high. Bradykinesia, or slowness of movement, happens when the dopamine is too low. And that often coincides with when tremor occurs. The tremor is actually a little different than the tremor we see in other disorders like essential tremor, which doesn't flow as much from the basal ganglia. But yes, I agree. It's a curious thing that at some level, Parkinson's can be pro-movement, meaning causing a tremor that's involuntary, and simultaneously anti-movement, making you feel stiff and rigid and slow. So it's interesting, and there may be some scientists that have figured out why that is, but the brain is wired in very complicated ways. So
yeah, everybody's different, no question.
Everybody's different. So some patients will have one of these really bad and not the other ones. Some patients will have all of them. It really just depends.
Thank you.
And so those are the movement symptoms, but it turns out that, of course, Parkinson's disease affects a lot of other parts of the body. And in fact, the movement symptoms are relatively late in the progression of the disease. And often in retrospect, patients have had other types of symptoms for a very long time, sometimes even a decade or more. So constipation, difficulty with sleep, loss of sense of smell, depression. Some of those things are kind of pretty vague or non-specific symptoms, and some of them can go along with aging. And so for that reason, it's typically not until patients develop movement symptoms that the diagnosis is made. And in terms of therapy for Parkinson's disease, of course, a lot of it focuses on the underlying problem, which is a lack of dopamine. And so there are all types of medications out there. The list is constantly growing that basically aim to increase the amount or concentration of dopamine between nerve cells in an effort to try to replace the loss that occurs from the death of those cells in different parts of the brain. And as we talked about before, dopamine levels correlate with movement symptoms. So a dopamine poor state, which we would call, an off state, when dopamine levels are low, patients are typically slower, they're bradykinetic, they may have rigidity, they may have more tremor. And we contrast this with an on state, or a good movement function state, in which we think dopamine levels in the brain are higher, patients are more fluid, they may not have as much rigidity or tremor. And so the focus of many of our therapies, including the ones I'm going to talk about today, is trying to shift the balance of a person's day to more time in, and again, what we call the on state. And this is that chart I was referencing before. So the y-axis here is kind of dopamine. You can think of it kind of as where a person is in terms of their movements. So good is kind of between these dashed lines. Above it, patients are dyskinetic. Below it, they're slow and rigid and tremulous. The goal is really to spend as much time as possible in this sweet spot, or this zone in the middle. And that's when dopamine levels, as we talked about, are at a physiologic or expected, a normal level in the brain. When dopamine levels get too high, patients get dyskinesias. When they're too low, we see these other symptoms. And in the beginning of the disease, if you take a dose of oral dopamine, basically levodopa or carbidopa-levodopa, also called Sinemet, there's a gradual rise in the effect of the drug and correlatingly a rise in the level of dopamine in the brain, and then it slowly tails off. But as the disease progresses, patients become more brittle, and you end up seesawing between this place where you're slow, you're tremulous, and then you tend to overshoot and end up dyskinetic with a dose of dopamine, and you may have to dose it multiple times a day to really try to find yourself in this sweet spot. And this is a challenge that many patients develop, typically, 4 to 6 years after initiation of medications for Parkinson's. It's quite variable. I'll see patients that get this within a couple of years. I'll see patients that have lived with Parkinson's for 10 years and haven't developed it yet. And so we're not sure why it happens. But again, we call these motor complications. And specifically, some examples are a situation where the medications feel like they wear off rapidly and you have to redose and redose and redose throughout the day. Dyskinesia, so these abnormal dancing or writhing movements can look like somebody's fidgety or uncomfortable, that occur when dopamine levels are too high. And then sometimes I'll see patients that despite even good levels of dopamine will have a tremor that just doesn't seem to respond anymore. So what we call medication-resistant tremor. We think that these affect at least half of patients with Parkinson's disease. And as I mentioned, on average, it's somewhere around 5 years after starting medications. So with that, in terms of background, I want to focus most of the time we have on what the surgery is or what the surgeries are, and when we think about them, what they're good for, what they're not good for, and then what's changing about surgery. So big picture, who should consider surgery? Really any patient that has developed motor complications. And again, that's need to frequently dose the medication throughout the day, developing dyskinesias, or having a tremor that stops responding to medicines. Those are the most common examples. We used to do a procedure, not so much anymore, called a pallidotomy. This is not quite what Michael J. Fox had, but kind of similar. Basically, a probe is introduced into the brain and a tiny spot is burned. And the goal is really to try to interrupt the circuit that's causing these pathologic movements or abnormal movements. You can see these little lesions in the brain. This patient had one on both sides, and you can also see in this case the tract that was used to make the lesion. There's been a resurgence in interest in this procedure. It was largely just a historical procedure until recently, when there's been some studies of it looking at potentially using focused ultrasound to do this. And I'll talk a little bit about focused ultrasound later. But there may be a return of this procedure in the coming years. But largely this has been replaced for the last decade or more by deep brain stimulation, or DBS, which I think Greg already referenced. So this is a procedure that was studied in the 70s and 80s and was ultimately approved by the FDA in the 1990s, first for essential tremor and then later in 2002 for Parkinson's. And there's been hundreds of thousands of implants since then. I implant, a couple of these on a weekly basis. The system consists of a tiny wire that's implanted into the brain that delivers very targeted pulses of electricity that are aimed at interrupting these abnormal rhythms that develop that we think are related to the movement symptoms. This has advantages over pallidotomy in that it's reversible. It can be turned off or taken out. And it's also flexible. The symptoms change over time, as you both have seen. And we can adapt to your changing symptoms by changing the settings of a stimulator as you need it. And so this is the mainstay of therapy for Parkinson's patients who have motor complications. This is just a schematic showing what it looks like. Like I said, there's an electrode in the brain. This is about a millimeter and a half wide. And it kind of runs under the scalp behind the ear, and then down to a little battery that's put under the collarbone. Excuse me. These are some, this is a CT reconstruction and then an X-ray from patients I've implanted, just to give you an idea of what these things look like. This is actually an outdated photo, but it's showing kind of what the batteries look like, and the wire in reference to a quarter, just to give you a size. These are pretty small, and for most people are fairly, not visible from the outside. But just depends on somebody's size and how much hair they have and so on. But generally, these are not too noticeable. Some of the newer ones are even smaller than this.
Doc, if you want, I don't know if you guys can see this or not, but really all I have is the little bumps from the buttons that hold the lead in place.
Yeah, so that's
on both sides.
Your video is a little small, so it's hard to see, but just to explain to folks who might watch this what Greg's talking about. Oops. So where the wire goes into the brain, around here, or sorry, where it goes through the skull, there's a tiny little locking cap that's installed on the skull, just under the skin. And the purpose of that is really twofold. It's to plug the hole that was created when we drilled to put the wire in. And number two, it has a little crimping mechanism to keep the wire from sliding in or out, because we want this wire to stay exactly at the depth that we put it in and not to move over time. And so, sometimes people, if you don't have a ton of hair, those can be visible, but otherwise these are, especially if you have hair, and it'll grow right back after surgery, and these are typically not visible. So.
Yeah, but I know a lot of people with Parkinson's that say, for vanity reasons, I don't want to appear to be, sick. I don't want to have weird things on my head, or like, I'm a relatively fit person, so my IPG, which you can see right here, I know where you can see that, has healed pretty good, but mine protrudes out because I don't have a lot of body fat.
Yeah, you're pretty thin. And also you're wearing a low cut shirt. I mean, if you're wearing a shirt like myself, it wouldn't be visible. One thing that can be done is, if for very thin people, I'll do this for really old ladies, sometimes, who are 100 pounds, I'll actually stick the battery underneath their muscle here, underneath a little bit of the pectoralis muscle, which actually helps to hide it quite a bit. But yeah, depending on what you're wearing, sometimes it can be seen. And yeah, I think there's cosmetic considerations, but I think it, of course, has to be weighed against the benefits that the device provides. And for most people, it's fairly dramatic. And so here I wanted to review a little bit of the data that we have on how this works, or does it work? Does it make a difference? Would it be worth getting? And the good news is we have more randomized controlled trials, which are the gold standard in medicine for DBS, than we have for almost anything else in neurosurgery in my field. So we have trials, for example, that show us that patients have improvements in their ability to perform activities of daily living. So this is a patient before surgery, or this is a cohort of patients before surgery. There's a big difference in their performance when they're off medicine versus on medicine. And actually that difference pretty much evaporates after surgery. You basically spend a lot more time during your day at your best movement function. And so there's not these wild peaks and valleys that are familiar to those that are struggling with medicines. So an improvement in what's called functional status, or ability to perform activities of everyday living. Patients have additional of their time at their best motor function. So the best studies suggest it's an additional 4 to 5 hours per day of your best movement function, which, when you think of how long we spend awake and how much of your time is with poor movement function, an additional 4 to 5 hours for most patients is very meaningful. And then most importantly, patients who get this surgery have consistently reported from study to study an improved quality of life across a variety of metrics. And typically these differences are not very subtle. So this is generally a pretty meaningful procedure for patients. And this is actually a tremor patient, I think, rather than a Parkinson's patient, but it's the same kind of thing. You can see kind of what things look like before the surgery and after. So the video will start with the patient trying to hold something still before surgery, or actually rather, I think it's after surgery, but just with the device turned off, and then he turns it on, and the next part of the video is just a few seconds later. This is off. So this is him tremoring. And you can see, it may still have little bits of tremor here and there, but obviously quite a big difference after the device is turned on. These two clips are 30 seconds apart. Here's another example patient. This was, again, I think a tremor patient, but he had severe tremor on both sides. He was a little bit older, and so we treated one side with DBS, and we can talk a little bit about treating one side versus both sides, but I'll let you guess which of the two sides he had treated.
Wow.
So, sometimes the differences that patients notice can be very striking. This guy had a great result and subsequently went on to have the other side treated too. So just to summarize the benefits that we have from clinical trials, so patients have improvements in their functional status, their ability to do the things around the house and in daily life, more good on time per day, and on average 4 to 5 hours. A reduction in the cardinal symptoms, the movement symptoms of Parkinson's, so tremor, stiffness, slowness, and dystonia. I thought I had a slide, but maybe it didn't come through, but all the studies we have show that patients with Parkinson's that get this procedure typically see pretty marked reductions in their medication needs after surgery. And then most importantly, patients describe a better quality of life. When I meet a patient in the office, I have a few things that I go over to try to set expectations, and I even have handouts that I provide for patients that I'll show you at the end or linked on my website. But I tell patients that DBS is effective for movement symptoms of Parkinson's, especially those that have responded to Sinemet or levodopa. DBS, however, is not effective for non-movement symptoms. So sense of smell, difficulty with sleep, constipation, these things that are not movement related, we think don't really respond to DBS like the movement symptoms. DBS is not a cure. So Parkinson's, we don't have a cure yet for. We're investigating gene therapy and lots of other things that I think are years and years away from clinical use. But DBS typically for patients that get DBS for Parkinson's patients typically sets back their symptom clock by more or less 5 years. So patients feel 5 years different, 5 years earlier in their disease than they actually are based on their true chronologic disease age. And DBS provides more on time, as we talked about, but it typically doesn't dramatically improve the quality of that on time. It's just that you have more of it and you spend less time being rigid and stiff and slow. So who is a candidate for DBS? These are just rules of thumb. I mean, there's always nuances to any individual patient, but in general, we look for patients that have had a diagnosis for several years, and I'll go over why that is. Those that have had a good response to Sinemet, at least at some point. Maybe that response is getting worse and worse over time, but at some point had a decent response to Sinemet, and those who have developed those things that we discussed before called motor complications. This is actually a sizable percentage of patients with Parkinson's disease over time, and yet the percent of eligible patients that ever get an operation is actually pretty low. It's somewhere between 15 and 20% of those who would be good candidates. And the greatest barrier is that there's simply not the awareness in the community that we would hope. Most eligible patients are never even referred for surgery or an evaluation for surgery. And it's a real shame, and it's what we're trying to change with talks like this. This is not a perfect solution for everybody, but we want to get the word out there so that the patients that would benefit, that could enjoy additional quality of life and years of life, do hear about this therapy and at least give it a consideration. When should a patient think about DBS? So we talked a little bit about we don't do it the moment a patient is diagnosed. We wait for some of these things to develop. We used to wait longer, and we have studies. This is a study, I think, from 2013 that established that it's actually better not to treat patients when it's super advanced, to try to get them a little bit earlier in the disease, so that they just have longer to benefit from the device. The device doesn't really wear off in the way that most of us think about it. And so we're really trying to shift the balance of therapy away from the patients that are very severely affected to those that are more modestly affected and will regain a lot more of their independence and stand to benefit from the device for more years. Why not implant DBS right after a patient is diagnosed? This is a question I often get. I think there's a few reasons. So number one, very simply, is not every patient with Parkinson's is going to end up needing this. And so in medicine, we try to start with the less invasive things and escalate from there. And so we start, of course, first with medicines. Some patients do great with medicines for a very long time. And I think, Greg, you said it was something like 10 years or 12 years from the time of your diagnosis to when you had surgery. That's great.
Mm-hmm.
That's ideal, but no reason to put you through a procedure that has some risk until you really need it. The other reason is that there can be other disorders that are less common than Parkinson's that cause a Parkinson's-like syndrome that we do not treat with DBS, that we treat in different ways. And so examples of those are multisystem atrophy or MSA, PSP or progressive supranuclear palsy, cortical basal degeneration. These are tough diagnoses that don't really act like Parkinson's, but they can look like Parkinson's in the very beginning. And importantly, we know that patients don't do well with DBS if they have these disorders. These are all less common, far less common than Parkinson's disease, but we don't want to inadvertently do surgery on a patient that actually has one of these disorders. A little bit about the nuts and bolts of surgery. So as Greg referenced before, there's a couple targets in the brain that we use for Parkinson's. The subthalamic nucleus, or STN, which is the orange blob that you see here. And then the globus pallidus internus, or GPI, which is the dark blue. And this is kind of where we typically will try to implant. Natural question, is one of these targets better than the other? We have a big study, the biggest in the world, was done at the VA here in the United States, and it showed that big picture, these two targets are equivalent, but there are minor differences. So patients with STN DBS typically see more medication reduction. Patients with GPI may have a lower risk of cognitive effects or psychiatric effects. And so we kind of customize the choice of target based on a patient's particular symptoms and history and other diagnoses that they might have. I think nowadays in the United States, most patients are getting STN, but there are still exceptions. I did GPI just a couple weeks ago. It really just depends on a patient's particular situation. What does the process of surgery look like? What's the experience? So there's a number of steps, and I'll try to go through them here quickly. But first off is a diagnosis. This is usually a neurologist, often a general neurologist, and may get escalated to a movement disorder specialist over time. And this triggers the initiation of medications, Sinemet being the most common one, but there's literally a laundry list of other medicines that probably you guys are more familiar with than I am. Over time, patients may develop, as we talked about, motor complications. And in an ideal world, this is what would trigger an evaluation for surgery. So what does the evaluation consist of? A few things. So meeting with someone like myself, a surgeon, an on-off test, or sometimes this is called a levodopa sensitivity test or levodopa challenge. Basically, this is meeting with a neurologist or a physical therapist when you are off medicine, for 10, 15 minutes, and then again when you are on medicine, and they conduct a brief physical exam and quantify some of your movement symptoms. And what we're looking for is that you have a reasonable sensitivity to levodopa, to Sinemet, because our best predictor of who gets better from DBS and what is going to get better from DBS is who and what get better from Sinemet. It's not a perfect predictor. For example, some patients don't have benefit anymore with medications with their tremor, but almost all patients will get tremor benefit with surgery. but it gives us a general idea, is this somebody that is likely to benefit from surgery? Patients also get a neuropsychology evaluation. So this is a meeting with a cognitive doctor that does a screening exam to look at different cognitive and behavioral metrics, basically just trying to make sure that a patient is suitable and stable to have this kind of procedure. We're also trying to make sure there's no evidence of dementia, of severe cognitive impairment, because we know that patients who have significant cognitive impairment often don't do well with the surgery and are at a higher risk of complications from the surgery. And then finally, there are some scans of the brain that are done in preparation for the surgery. I always get a CT scan and an MRI. I think most surgeons do that. But these allow us to see the targets in the brain and to plan the surgery ahead of time. Common question, I actually kind of already went over this. So neuropsychology, it really helps us choose the right patients for surgery. If we find a patient has a fair number of cognitive deficits, we might decide to do it just a one-sided surgery and then see how a patient does before we bring them back and do the other side. Or we may pick a different target. As I mentioned, the GPI tends to have fewer cognitive effects than the STN, so we may steer a little bit toward the GPI if a patient has some vulnerability on their testing. And importantly, most insurance companies insist and require this, and so it is kind of the standard of practice for us to get an evaluation on just about everybody. And then there's the surgery. So that's what I did this morning. Most surgeons, most centers will divide this into two procedures. The first procedure is the bigger one. That's where the wire or wires are implanted into the brain. My patients will stay one hospital night and go home the next morning. And then the second stage is usually done one to 2 weeks later, and that's putting the IPG or the battery in, and that's an outpatient surgery. A little bit about what the surgery is like. I think it's important to note that this is how I perform the surgery. There's lots of different ways to do this. And I think if someone's considering this, he or she should talk with the surgeon that's going to be doing it. But this is how I do it. So I use a surgical robot that allows me to create a 3D model of the head and brain, to pick a target in the brain. This is me setting up the robot. This is the robotic arm. Here's the patient's head. We have a CT scanner around the patient so that we can actually check our accuracy during the procedure. The robot is a really helpful tool that basically robots are really good at precision tasks. So it's able to aim at the target I chose in the brain with sub-millimeter accuracy. The robot never, it doesn't do the surgery. It doesn't touch the patient. It's basically just a precision aiming tool. And then we put the probe in. You can see here's the white dot is the probe, in this case, the electrode. The green cursor is what I was aiming for. And so you can see we're right on top of what I was aiming for, which is pretty typical with this system. I do 2-3 minutes of recordings just to look at the brain rhythms to see that we're in the right spot. We're seeing the effects, we're seeing the abnormal brain rhythms, in particular the beta rhythm. These peaks are in the beta band that we know is correlated with some of the symptoms of Parkinson's. And then I typically will do about 10 minutes of testing. So this means we turn the device on temporarily through a temporary battery, and we have the patient, move their arm. We look for tremor. We ask the patient if they're feeling any side effects. And this I like because it only adds a few minutes to the procedure, and it really helps me be sure that the patient's going to come back and be satisfied that we got the clinical effects that we want and we don't have side effects. I never want somebody to get turned on in the neurologist's office and to have it be something that we did not expect. So I think this is just a brief video of us doing some testing of a patient. We don't have to belabor that. And then in the second procedure, part 2, I make a little nick right here, and then I make a little incision beneath the collarbone, and we have a tunneler that lets us send the wire under the skin down to the battery. Common question I get from patients is what are the risks of this procedure? Of course, it's brain surgery, so there are some risks, but fortunately, this has been around for it has been around for 25 years in the US, so we've really refined how we do this, and things are a lot safer than they used to be. And so there's a risk of infection. if you look in the literature, they'll say 5, 6, 7%. In my experience, it's well less than 1%. There's a chance that therapy doesn't meet expectations, which is why I try to be really clear with patients in the office beforehand about what to expect that might get better and what might not. There's a chance of cognitive changes, which for most patients is not perceptible. But that's in part because we choose patients really carefully, and we do that screening exam, as I mentioned, before surgery. And then the scary one is bleeding in the brain. I do this procedure multiple per week, and I think the last time I had a bleed was 3.5 years ago, and that patient recovered completely. And so it's not that it can't happen, it certainly can, but fortunately the risk is low. And most patients that have a bleed don't really have any symptoms. But it is just the nature of poking something into the brain. When I had made this talk for another group, I was asked to create a slide that was just kind of summarizing what patients should think about or ask their surgeon. And so people sometimes find this helpful to go over. But again, we've talked about some of this, but I think patients should try to understand which of their symptoms are likely to improve, which are not likely to improve if they have the surgery. Should we treat both sides of the brain? So one side of the brain is corresponded to the symptoms on the opposite side of the body. Both sides can be treated. One side can be treated. One side can be treated, and then the other side can be treated at a later date. There are specifics to why we make those decisions that I think are important to discuss. Should I get a rechargeable battery? So we have systems that are non-rechargeable and those that require recharging. A non-rechargeable means you don't mess with it, and it has a lifespan, and when it runs out, you get it replaced. My patients, the batteries are lasting 7 to 10 years, so that's pretty good. And that means that you're not coming back for surgery to get it replaced very often. But some patients need a lot more current or voltage, and the battery may run out more quickly. And for those patients, a rechargeable battery may make more sense. That's something where you have kind of a thing that you wear over your shoulder, charges the battery up. You probably have to do it a couple times a week, or sometimes more, sometimes less. But it means that battery lifespan will be lengthened, and you may not need to replace it for 12 years or more. I think it's important to understand how your surgeon performs the surgery. Are you going to be awake? Do you need to be tested? What should you expect? Should you take your medicines on the morning of surgery? All of these things, I think, if you understand them ahead of time, it just means that there's less anxiety and stress on the day of. And then what to expect after surgery. What's the healing process like? What kind of sutures will you use? Do they need to come out? Is there anything special I should do for my incisions? I like patients to shower the very next day because I think it helps keep things clean, but not every surgeon is like that and will say the same thing. In terms of post-op care after surgery, there's a couple visits typically with your neurologist. That are often spaced a little bit apart, where the device is kind of fine-tuned. It's turned on and then slowly ramped up so that you get used to the therapy. And as the therapy is getting ramped up, often your medicines are being reduced. And then typically after that, patients will establish a routine where they come back to their doctor, usually their neurologist, every few months.
Right. Grab my charges.
And then, for patients that have rechargeable systems, you charge it at home, and those that don't, you periodically check in with your neurologist every few months, and they'll check the battery and just make sure that it's not running down and needing to be replaced.
Collar.
Quickly, I wanted to go through some of the new stuff that we have. So there's been advances in the design of the leads that go into the brain. And so we now have what's called segmentation of these leads, which basically allows us to deliver, instead of delivering electricity kind of 360 degrees circumferentially around an electrode, we can give directional stimulation, which allows us to preferentially stimulate some parts of the brain and not stimulate other parts of the brain. This is kind of a neat trick. If your lead is kind of on the edge of where it needs to be, I find that in practice, very few, if any, of my patients actually use this, but it is something that's an extra tool in the belt of your neurologist for programming. Robotic implantation, I already spoke about that at length. So I use this surgical robot. I think it's fantastic. There's lots of different ways to do this procedure. There's no one way that is better than all others. It's just important that your surgeon has a routine and that the results are reproducible. I think this is pretty cool. So some DBS systems, Medtronic in particular, now have a sensing capability, so they can actually listen to the brain rhythms that correspond to the movement symptoms that patients have. And the idea is, historically and currently, DBS is delivered at the same level all the time, 24/7, unless you turn it off or turn it down. The next generation of system is basically going to be dynamic. Your symptoms change throughout the day. Your need for therapy, your need for medicines changes throughout the day. And so it's really cool that this device has a way to listen to the brain, quantify the brain rhythms that it's seeing that are abnormal. And then there's a feature that we hope is going to be unlocked soon that allows the device to change the amount of current that it's giving you based on your brain rhythms throughout the day. So this exists currently in the Medtronic device. It's not in use in the United States, but it is in use in Japan. And when it's approved in the United States, the patients who've been implanted recently will be able to just switch it on inside the device wirelessly. We were the first ones in Colorado to implant one of these. Some of the systems, Abbott, actually, sorry, just one system right now, Abbott, and I think soon to be Medtronic, have the ability to perform remote programming, so you don't have to be physically in the same place as your neurologist. They can program the device over a video conference like this one. It's a little tricky sometimes to gauge your symptoms if you're not physically there, but this is a nice option for patients who need some fine tuning, who may live very far away from their doctor. Another slide just kind of on some of the developments in lead technology. We're also investigating new surgical targets. So the caudal zone inserta is an area that's seen promise in Europe for Parkinson's and also for tremor. I've implanted this a couple times for patients that have both essential tremor and Parkinson's disease because it can help with both of them. And then, importantly, we now have options for patients whose dominant symptom or maybe only symptom is tremor, or patients who are just not good candidates or don't want to have DBS. And so I wanted to spend a few minutes on this. The mainstay of this therapy is something called a thalamotomy, which is creating a tiny lesion in a part of the brain called the thalamus, or specifically the VIM nucleus of the thalamus. This is what we use to treat patients with essential tremor, but it also helps patients with Parkinson's disease in that it can help their tremor. The nice thing about a thalamotomy, there's no incision, there's no implant. This is an outpatient procedure, so you don't stay in the hospital, and it can be quite effective. So Gamma knife has largely been replaced by this technology, focused ultrasound. So I do a fair amount of this for patients with essential tremor and to a lesser degree with Parkinson's disease. This is a cool technology that consists of an ultrasound array that's put around your head. And there's about 1,000 sound wave emitters. And this is, I should say, very high frequency sound wave. You cannot hear this. A dog can't even hear it. It's very high frequency, but these waves all kind of converge on a spot in the brain, as you see illustrated here. And it's enough energy just to heat that spot up for just a few seconds. And in doing so, we can create a tiny lesion there without needing to put a probe in the brain or anything like that. And that translates into immediate reduction or relief of tremor. So this is what the procedure looks like. I'm in the control room. The patient is in the MRI scanner. We pick a target in the brain, and then we can see it heat up as we deliver the ultrasound energy. And I'll go in periodically and test the patient, and you can see this patient's ability to draw a spiral, to draw a straight line, to write his name improves markedly over the course of the procedure. This procedure takes, an hour and a half or thereabouts. It creates a tiny lesion in the brain that you can see on the MRI here. And, typically the difference is quite striking. So this is a patient on the table at the start of the procedure and on the table at the end, trying to draw a spiral. I think just a couple more example patients. This is actually a patient with Parkinson's disease who got the procedure, had quite a bad tremor beforehand. When she tried to draw a spiral, her hand would just kind of hit the page like this, and so she couldn't do it. And here she is at the end. And I think I can play a little video showing her.
Treat that one, yeah.
You can see which of the two hands here was treated.
That's great. Treat that
Um,
one.
So we think that based on studies we have now that have followed patients for 5 years, that this tremor relief is pretty durable, and patients report a significantly improved quality of life. One thing to note about ultrasound, it's a great procedure, but it does require, unfortunately, shaving the entire head. Ultrasound waves don't pass through the hair, and so we do have to shave the head in order to get the energy into the skull. The hair grows back, you know, but this is a consideration certainly for women when I meet them in clinic. So with that, I'll try to wrap up. Again, you know, I put a link to my website down here at the bottom. I think this is a good resource for information about Parkinson's, about tremor, about DBS, about ultrasound. I wrote all of the content on that website, so I can vouch for it. I also have a few PDFs that I give as handouts to patients who are diagnosed with one of these disorders, or who are considering one or multiple of these procedures that kind of summarizes some of the stuff we've talked about today. Here's an example of one of those guides. But with that, I'll kind of wrap up, and happy to take any questions that you guys might have.
What do you see, Doc, on the horizon? Things that are going to make change. By the way, this is while we've been talking, I've been recharging my rechargeable.
Oh yeah, that's a great, that's great to get it on camera. So for most people, as you're showing, it looks almost like a neck pillow that you would wear on an airplane, except that it has this little charging, module that you would put over your skin, and then it wirelessly charges the device. And so how long do you need to use it when you recharge?
I would say I tend to sit there for 10, 12 minutes.
Yeah.
So
And how many times a week typically?
once a week.
Yeah, so that's pretty minimal burden. Most of us can find 10, 12 minutes watching TV or what have you, just to slap it on, and you just put on your calendar, hey, this is something I do every Sunday. And it's pretty easy. The Boston Scientific battery is pretty efficient. And so it's a nice option for patients that really want to avoid having to come back and having the battery swapped out over time.
Yeah, and for me, it seemed to make a lot of sense because literally you're just wearing a yoke like this, and potentially that's going to last 20, 25 years. I don't know if I'm going to last.
Yeah, maybe the company says it. I'll believe it when I see it. I think 12 to 15 years is pretty reasonable expectation, but
yeah,
I'm not sure you want the same battery in for 25 years because the technology is going to change, and you want to be able to use the newest stuff. And so if it lasts 25 years, that's fantastic, but we'll see.
Yeah.
So you asked kind of what was on the horizon, I think. Sorry.
Yeah.
For me, I think the main things are going to be, or the main thing rather is going to be the development of what's called closed loop therapy. And I talked a bit about this, but what this means is the ability of the system to sense your symptom state at any given moment during the day and automatically adjust the therapy that you're getting.
Yeah.
So, your symptoms do this during the day. There's no reason your therapy shouldn't do that also. And it may mean that you end up getting much less energy delivered throughout the day, that you have fewer dyskinesias. I think there's a lot of potential advantages. And so that's I think, relatively near on the horizon. The exciting thing someday would be, can we do genetic engineering to try to get cells in the brain to start making dopamine again? There have been lots of trials of that, and unfortunately nothing has been successful, but frankly, I think it's just a matter of time, and hopefully we find the right cocktail and target and gene vector and everything. But that's, the holy grail, which could mean that maybe you get an injection in your brain that helps your Parkinson's, and you don't have to have an implant or an ultrasound or something like that. But that's, I think, a little ways away.
That was one of them in my decision making. Should I go with focus ultrasound or gamma knife or DBS or just keep taking drugs, I found that it made sense that I look for what I call upward scalable architecture. I know that science is always working on improving and coming up with something better. So I wanted something that gave me the ability to have something that I could change my mind. I could add a symptom, symptom relief to it. Amazingly, I have regained my sense of smell after 15 years of certain items. I can't smell everything, but I can smell certain items. Tends to be citrus, tends to be acidic. But that was one of the benefits. And I know this for a fact, simply because when I had the DBS surgery, I then noticed suddenly I could smell when I went to my programming. I was like, sweetheart, where's some fig Newtons? I'm starving. And I opened the box of fig Newtons and I'm like, right away, one whip. And I went,
Wow, I think that's
I can smell
interesting.
this.
That's interesting. I wish I could tell you I understood it. It's certainly not something we expect or promise to patients.
Yeah.
But some patients do have symptoms that change after surgery that we can't explain or we don't expect. I mean, we're happy to take credit for it, but I wish I could tell you it was intended. I'm not sure how that happened.
What's your philosophy on a sleep versus awake surgery?
Yeah, and there's a vigorous debate out there, and I certainly don't think either one is wrong. I mean, fundamentally, you want the technique that your surgeon is most experienced with and is safest and likely to give you the best result. Historically, they were all done awake, and then in recent years, there's been a gradual shift towards a sleep. And I think we have good data to suggest that sleep surgery is safe. My perspective is really twofold. Number one, actually, awake surgery for me is faster. And then the patient doesn't have to have general anesthesia. So some patients with Parkinson's can be very sensitive to general anesthesia, and keeping them under for a couple hours is not a trivial thing. So I've generally preferred to do it awake. And then the flip side of that is I can then make sure that the stimulator is going to cause the benefit that I want and not cause side effects, which is not something you can always glean from just imaging. I think all surgeons have had cases where it looks like it's in a good spot, but strangely, the patient doesn't have as much benefit as you're expecting, or they have unexpected side effects. And conversely, there have been cases where, it looks like it's off on the CT scan, but in fact, they get fantastic results. And so we're still learning about the imaging. The imaging is still changing. So I do it awake. But if I have a patient that really, really can't tolerate it, we'll do it asleep. But I could tell you in, the last few hundred cases, I have not had to convert a patient who couldn't tolerate it. In other words, I haven't had to put a patient to sleep during the procedure because they were having a hard time. So I don't think there's right or wrong. I mean, I think patients usually want to be asleep, but it's just a matter of what your surgeon is comfortable, experienced with, and what gives them the best results. So,
yeah. I personally would suggest to anybody to stay awake, simply because,
you were awake
like you
for years?
said, yes, absolutely. And I wanted it to, number one, I believe there's a correlation to the length of the surgery and the risk involved.
Yep.
The
absolutely.
longer you go, the more there's infection, the more there's bleeding in the brain. I had a good friend who lives back in Colorado. I had my DBS performed here in Florida, and specifically in Pensacola. And he had some bleeding on the brain, unfortunately, had to stop. But just as you said, it's not nearly as terrible. And after a month, he was able to go through healing. And then continue with both, because he had bilateral two probes. So I think that Parkinson's, as you know, is everybody's Parkinson's is a little bit different. Everybody's responses to DBS is a little bit different. I think, for me, it was a pretty simple choice. I was starting to get too many dyskinesias. I was starting to have to take, my meds every 2 hours kind of thing. Like you talked about, it's really that gap in time slide that you have.
Yeah, it starts to kind of narrow and narrow your benefit. Yeah.
Yeah. And so for me, it seemed like it was pretty simple. I would, I'm a walking poster child for this thing now.
Well, good.
Because not only, according to my wife, not only have I the symptoms balanced out, but I'm back to having the energy that I had prior to Parkinson's. Because as a person with Parkinson's, and I didn't really even notice this, but just gradually over the 12 years, I became I've always been a hyperactive person, and I became kind of lethargic, took a lot of naps and stuff like that. And I'm back to being, the Greg Richer of old with the energy and, let's go do this, let's go do that, let's go fishing, let's go paddleboarding, let's go.
Yeah. No,
And to
it does
me,
help,
that's like
and
giving your
I
life
think
back.
some of it is physical, and some of it, frankly, is probably psychological. You feel like something has been done, you feel different, and you feel that there's hope, and that there's a change in your daily experience, and so that can be motivating. I mean, depression and Parkinson's is a real thing. We know that, and we know that there are things that help, whether it's medications, whether it's exercise. I mean, there's tremendous evidence for the benefits of exercise, regular exercise, I'm sure, as you guys know, both for Parkinson's and then also for depression. And so, this is something that kind of, because it's such a defined thing that happens, and then it gets turned on, you kind of feel like you're turning over a new leaf and you've got a new lease. And so for some patients that can translate into a really different outlook and a different energy level. And it sounds like that was the case for you.
Yeah, my neurologist says, well, this could be, oh, geez, I'm drawing a blank on the word. What do you believe when you believe something, but you can't medically prove it?
A
Placebo
effect, or yeah.
Geez, why couldn't I come up with that? But anyways, she said, well, I think this is a little more placebo. And I told her, do I care?
No, as long as it sticks around. I mean, who cares what it's from? I mean, if you feel good and you're doing well, I'll take a placebo effect. I certainly have patients for some surgeries that feels like there's some placebo, but if they're doing well,
Yeah.
That's right.
Yeah.
Oh, bummer. I have a lot of energy. So anyways, thank you very much. You've been very informative, and
Oh, my pleasure. Thank you guys
do
for having me.
a good job of succinctly putting everything together.
This was really great. Thank you so much.
Of course, my pleasure, and always happy to field any questions. But thanks again for sharing your Friday morning, afternoon with me, and look forward to maybe seeing you guys someday.
Absolutely. Thank you again for your time. Really appreciate it.
Okay, you guys have a good weekend.
Matthew.
Thanks,
where do you
everyone.
perform
Have a good
surgery?
weekend.
Oh, sorry, what was that? Sorry, I missed that.
Where do you perform surgery?
So I do the brain part at Swedish, so kind of South Denver.
Yeah, I know where that is. I'm in Denver.
Oh, okay, great.
Brian, did you have any other questions before we close?
No, I just wanted to say thank you to Matthew. I really like the chart that shows on and off. I started on Cinemet, but it wasn't doing anything for my tremor. And I had almost no other symptoms. And as I said before, my symptoms are very slow to develop, and I feel grateful about that.
Yeah, so, regarding that, I think as I referenced, but just to make sure it's clear, so I kind of cited what we usually think about in terms of when somebody should seek treatment, in terms of developing motor complications and so on. One exception to that is tremor dominant patients. So there are some patients, for reasons we don't understand, that have Parkinson's and have very significant tremor, but the medicine doesn't help the tremor, or it helps initially and then it stops working. And so that is a category of patient where actually we usually think about surgery earlier, because we know that tremor almost always is very responsive to surgery, even when it doesn't respond to medicines. And so I think I had tremor dominant on a few of the slides, but that is one type of patient that we actually think about and treat a little bit differently. And so even if you don't have some of those other things that I talked about, dyskinesias or wearing off and so on, we do think about earlier surgery sometimes for tremor dominant patients.
And I'll speak to that. My first spiral that I drew with my tremor looked very similar to the ladies with just the wild marks all around. And straight line. Oh yeah, sure, straight line. And when they turn that on, and suddenly you go, ooh.
Yeah, it's typically
there's not
almost,
many feelings like that on earth.
Yeah, it's why this kind of surgery never gets old. It was an essential tremor patient, but I had that this morning, and I got a bunch of people who just start crying on the operating room table. It's a very rewarding experience.
Yeah,
so.
Absolutely.
Yeah.
Thank you for your help.
Yeah, thank you guys.
Thank you again.
Bye-bye.
Really appreciate it. Everyone have a good weekend. Thanks.